Hello, and welcome to Together at GRCC. Radiologic technology is a field that plays a crucial role in healthcare. Today, we're taking a closer look at what it takes to become a radiologic technologist, the challenges and rewards of the profession, and how GRCC is preparing students for careers in this essential field. From working in diagnostic radiography and computed tomography to leading one of GRCC's standout programs, this guest has done it all. She started her journey right here at GRCC before earning degrees from Grand Valley and Ferris. And now she's shaping the future of RT education as the program director. Please welcome Julie Lackscheide. Welcome, Julie.
Thank you.
How are you doing today?
I'm doing good.
Good. So just to get started, can you share a little bit about your background and what led you to RadTech? Is RadTech, because I tried to pronounce that, radiologic technology.
Good. Yep.
Yeah. And so do most people just say RadTech?
Yeah, or we say RT. Yep.
Okay.
Which sometimes gets confused for respiratory therapy, but yeah.
It doesn't really roll off the tongue.
It does
really.
not. Nope. Yep.
All right. So can you tell me about your background?
Yeah. So I knew I wanted to be in healthcare, I think, more than anything. But specifically, I knew I did not want to be a nurse. I didn't want to have that long of contact with people. I like people, but sometimes you have a really great person you're with and you get to be with them for a long time. And sometimes it's the exact opposite. And with imaging, we get to have lots of contact with people, but pretty short amounts of time, pretty quick amounts of time. So I just knew that I wanted to be in healthcare. I didn't necessarily want to be with the same people all the time in healthcare. And that's kind of what drew me to imaging. Okay. I also absolutely love what the human body can do, specifically what it does wrong. I know that sounds kind of not great, but it's just very interesting how the body can change on its own, sometimes for the good and bad, or how much it can be damaged and still repair itself. So I love being able to see that imaging or the inside of a person in those aspects.
RadTech is such a critical field in healthcare. For those that may not be familiar, can you explain what your profession does?
Yeah, so we are the large group that does a lot of the diagnosing of patients. So between us and like laboratory, we are a huge part of how a patient gets diagnosed and how specifically they get treated. There's always that clinical hands-on aspect that they do to be able to diagnose a patient, but quite often they have to use imaging to assist that or laboratory services in order to treat the patient appropriately. And so we perform exams that help diagnose patients, and that can just be with a plain film x-ray or just a diagnostic x-ray. We also do what's called fluoroscopy studies, and that's where we're either having the patient ingest contrast so that we can see inside a little bit easier, or it's an invasive procedure where they're inserting a needle and inserting contrast as well, or taking off fluids to be able to diagnose the patient, send it to lab, and actually get a good diagnosis. Wow. We are also in surgical procedures quite often, which is an area that I think a lot of people don't realize. Yeah. We have something that we use that's called a C-arm, and it literally looks like a C. Okay. It produces radiation in the receptors on the opposite side of the C, and we're able to assist in procedures where the physician may not want to cut the patient open really large, and so we can help see inside the body and assist that procedure without them making massive incisions. So we are in there quite a bit for orthopedic studies, so replacements or trying to fix a really bad fracture. We also do some urological studies, so things pertaining to the urinary system, like stones and things like that. Yeah. So lots of different and interesting things for sure.
So this field over time, I remember a long time ago having to go for one, and it would take like 5 days before they got the image back. And now it's like the same day they have the image back.
Yep, it's instant. So we used to be, back when I was in the program, I graduated in 2004, we used film screens. So we literally had to take the pictures on a film, go into the darkroom and process them. And then those films would literally be placed into a jacket, a film jacket, and they would be kind of transported around the hospital to the people that needed to read them, the radiologists. Now things are all digital, so they can be sent anywhere. Sometimes, especially with overnight, we don't necessarily have a radiologist in-house. they can get sent to another location where a radiologist is, or even somewhere on the other side of the country where it is daytime and they're reading. It has not, unfortunately, changed the potential reading time of things as,
because
healthcare.
it needs to be passed on to the next department, essentially.
And we are in currently a shortage right now where we don't have enough people really to do anything in healthcare, including radiologists. So exams for reading are kind of pushed out quite a long time. We're short on technologists, so even getting the exam complete might be pushed out some time. Some people are waiting over a month to get an exam done. And then the reading time after that is pretty long sometimes. So technology has advanced, but unfortunately, we're just in a period where things are just taking long still.
Has AI been any talk in that field at all? I know it's
absolutely.
basically immersed itself into every in the fabric of society.
Absolutely, So we do have some parts of AI and imaging where there is a system that kind of pre-screens exams for things that are noticeable or out of the ordinary, but they still use a person, like a radiologist, to actually read that exam. So it kind of double checks that data. And it's only applied on certain exams. It's not applied on everything. We have lots of AI that is used in our digital acquiring of exams too, that removes certain things that are not beneficial to the image, which I think initially is concerning because we're like, that's taking away information. But lots of data of why it's beneficial and how it improves everything. Absolutely.
So you were a student here at GRCC.
I was, yeah.
So you started your education here and then went to GVSU in Ferris State. How did your time here shape your career?
I knew I really wanted to be in education. Even working in the clinical site after graduation, we always worked with students. I worked at always a teaching hospital or a teaching hospital situation. And I loved talking about what I did. And I think because I loved it in the profession so much that it kind of came easily to be able to be in that position of being an educator. And I loved to learn and I loved to be challenged. So all of those things really were interesting to me. And when I went through the program, the faculty that was here, generally when faculty gets into a teaching position or a technologist gets into a teaching position, they don't leave for a really long time. It's your retirement, right? So I knew that it probably wasn't going to happen anytime soon. And actually, when I was finishing my bachelor's degree, I was contacted by a faculty member that I had and was asked if I wanted to come back and be an adjunct. And I absolutely did. I was actually at Grand Valley. I went to Grand Valley right after I finished here because I was going to go to school to be a PA. I knew that's what I really, really wanted to do. But I got that teaching offer and just never went back. Just kept staying and very much do enjoy it. I love what I do. I love imaging. I love teaching. It kind of melded both together really well. But I always joke and say I don't know what I want to be when I grow up because who knows what the next thing will bring.
Yeah, absolutely.
Yeah.
As the director of the program, the RT program, what are some of your main responsibilities?
Yeah, so being an accredited program, we do have a lot of responsibilities and standards that our program is held to. So a lot of my work is around the standards or meeting the standards of accreditation. A lot of data collection to ensure that our program is successful and improving that it's successful throughout the duration of the program, not just starting students and graduating students. There's lots of things in between that we have to make sure that we're meeting those specific standards and that data. I do lots of enrollment type duties, making sure students get into their classes appropriately, and including in that area textbook adoptions and things like that. Lots of responsibilities surrounding making sure that students are taking the also general education courses that they're supposed to be taking and in getting them in alignment with those. So a lot of that has to do with advising of students. We do a ton of advising. Our wait list is really long right now.
How long is it?
We're approaching about the 5-year mark.
Oh, wow.
So we're 4 to 5 years right now. We're very close to being 5 to 6.
Okay. Do people wait that long? I mean, that's an incredible wait.
Yeah. Yep. That's
so,
put your life on hold for sure. Not necessarily. So that's if every single person on the list actually said yes. And that doesn't happen often. So it could go down, but with it being that long, it doesn't go down significantly, in that way. That it just may shorten it by potentially a year.
Yeah.
we have just had this huge influx in interest in imaging, and I don't know what has happened to change that.
Is there a TV show or something that
everybody asks that. Is there a new show on that? And honestly, I don't watch TV like that because quite often it's very wrong that I just get frustrated the whole time.
You're like, they're doing it completely wrong. I need to step in here.
Yeah, they always hang x-rays backwards.
Okay.
So or they call us technicians, which we're not technicians, we're technologists. And I end up turning off the show for sure. So I do not watch healthcare shows.
Okay.
But I don't know what's been this huge influx. And a lot of K-12 institutions, KCTC has reached out a ton asking us to come and talk about imaging. But we have just had this massive increase in the wait list of our program. So it's a great thing. It's a great problem to have.
Absolutely.
And because we are short, but because we are short, I'm really limited on my clinical site placements. There's only so many places we can put students because we do have to maintain certain ratios at the clinical site of technologists to students. And so we're kind of like in this, cycle that we just are trying hard to break, but really are struggling to break.
Yeah.
Yeah.
Well, that's great.
Yeah.
What do people
problem,
do when they graduate? Like, what are their paths that they generally take as soon as they graduate?
Yeah. So most of our students end up receiving jobs at their clinical sites that they did their internship at. So they are in their clinical placement for 5 semesters of the 6 semesters that they're in the program. They do actually rotate to another institution and get to experience what that clinical environment is like for about 10 weeks. And some of our students get hired at their rotational site and not at their, what we call their home site. Okay. But they traditionally get a job within the hospital setting. We also have recently, in the last couple of years, started to incorporate other areas in our rotations. So we have a mobile company that we participate with that does mobile x-ray. So instead of sending individuals from like an assisted living center to the hospital to get an x-ray, the mobile company actually comes in and performs that x-ray right in the assisted living center. Yeah. It keeps people who are already potentially immunocompromised out of hospital settings or public settings, which is great. We also have partnered with a large orthopedic group here in town. So our students are getting an orthopedic rotation, so a specialty rotation. They do a lot of specialty imaging that we teach some of that in the program, but a lot of it is very specialized images that we would not necessarily see in a textbook. Okay. So they're doing that rotation along in that same thing. They're doing a pain injection type rotation where they do a lot of kind of the maintenance of a bad joint. They do pain injections in that area quite a bit. We also have a spine center that we've participated with where they do a lot of those things as well. Specialty procedures with the C-arm that I talked about with surgery, along with lots of pain injections to kind of maintain things before they decide to have surgery to help fix something. Yeah. So invasive, but not nearly as invasive like having surgery. Yeah, absolutely. Nice. Yeah. So we're giving students as much of an opportunity to find what area fits them the best, rather than just saying the only place that we can work is a hospital, because it's not. We're pretty much everywhere.
Avenues.
Absolutely. Yep.
Yeah. That's great.
Yeah.
Yeah. So what skills and abilities makes for a great student in that program?
Number one thing I think is flexibility and adaptability. In our program, we definitely teach what is foundation, so the basic tools and knowledge that every student needs to have to perform exams. But we know every single person is different. So if they can be flexible to the person and the environment in which they need to acquire those images, it's going to be the best tool. And I'm very much a type A personality. And I initially felt like, when I remember being in the program, that I needed to have things exactly my way. But there's times in which that is just thrown out the window, because that's not going to work, right, with your patient or the environment that you have to take it in. Because we are everywhere in the hospital. We're not just only in our own department. Yeah. So I think those are the two biggest things that really would help a student, being adaptable and being flexible to what's happening.
That's great. What is the makeup of your department in terms of faculty members and how many students?
Yeah. So we currently take in 24 students each fall. That's what we have a good ratio of placement of as of right now. And we have 2 full-time faculty members and 2 adjuncts currently. We're always looking for more adjuncts because the 2 full-time faculty, myself and my counterpart, are are very high in our load that absolutely would appreciate another individual that would be willing to teach. It's a little bit of a struggle considering that I just got done talking about how short we are. So there are, not a lot of us out there, especially with the qualifications that are needed beyond the associate's degree to be able to be in a program. That gets quite difficult.
That's great. So you said you have 24 because, is that what the hospitals want? Because with a waiting list, could you bump it up to 26?
We absolutely could. Yep.
Oh, yeah.
So we always have to be really mindful of
what jobs are out there.
Exactly.
Too.
We don't want to produce more technologists than what there is availability for. And the other part of it is it's not just diagnostic radiography that is short. It's MRI that's short, CT is short, interventional radiography is short. And so they are truly borrowing from departments or stealing from other departments to cross-train into these other modalities. And the cycle of being short just is not getting fixed. So this is also a question I get quite often about radiology is there's some people that are interested in those other modalities but don't really know how to get to them. In imaging, we have what's called a primary pathway or a secondary pathway. Primary pathway is you've graduated from an accredited program. You are then eligible to sit for that credential, and you've received that credential because you've passed that exam. You then have the opportunity to then cross-train into secondary pathways. So you have to have that primary first. So our primary pathway is radiography. It's really the stepping stone into other areas. We do have an MRI program here too that we take in about 5 to 7 students for. That is a primary pathway and a secondary pathway. Okay. So students can go through that program, graduate, and then sit for that credential. Or I have technologists that have already gone through a program but want to learn MRI and just haven't had that opportunity. They could then go through that program. Wow. So after X-ray, students have an opportunity to cross-train into interventional, CT, MRI, mammography, bone densitometry. There's lots of other areas that you can go into. And I think that was probably one of the things that interested me the most was that opportunity or that potential, because I knew I was going to get bored. If I wasn't constantly doing something new, I knew I was going to have to find something else to do after. And I didn't always want to go back to school, even though I did. Yeah. But I went to CT pretty quickly after X-ray school. Okay. And so that's why I have both of those credentials and worked in CT for quite a few years. Because CT is more trauma, which I loved, a lot more unpredictability, and you had to be way more adaptable to patient condition.
Sounds like a really fast-paced environment.
Absolutely, yes. And X-ray is too. They're just different. X-ray is very laborious. You have to help, especially in trauma situations, help patients get into different positions. So it is very physical in moving patients all the time. In CT is the same, but it's one movement. It's one movement to a table. And then your machine acquires all of these images, and they're 3-dimensional images rather than a 2-dimensional image like an X-ray. But yes, it's very fast-paced. We used to do like 100 patients in a 12-hour day. Yeah. Wow. Yep.
So you drank a lot of coffee.
I did. Still do, I feel like. Yes. Yeah. Yeah. And I traditionally, working at the hospital, always worked anywhere from, I felt like if I was going to go there, I wanted to be there all day. Yeah. So I worked 12 to 16 hours pretty traditionally. Yeah.
Okay. Wow.
Yep.
So do you do normally like 3 shifts then?
Yeah, I was what we call a bailer for quite a few years. When I was finishing up my bachelor's degree, I was going to school full time, and really the only way that I could make that work and work essentially full time was to be a bailer, which is a weekend only position. Okay. It's changed a million times since then, but I basically worked up to 2 16-hour shifts, Saturday and Sunday. And so I would get my full week in 2 days.
Oh my gosh.
And on, routinely I'd work.
So about Monday, could you even do anything on Monday?
I had class.
Oh my gosh.
And I had 2 kids.
I'd have like 2 picks in my eyes.
Yes. Yep. And I had 2 small kids. So,
oh my gosh.
Yes. So I just,
I don't. The model.
Yeah. I would say I don't remember large portions of time because I was so tired, but, and I don't condone anyone doing that, but I did it.
It was the way that for you to get it done.
Absolutely. Yeah. Yep.
Well, thank you for coming on Together at GRCC. Do you have any last statements you'd like to make before we sign off?
I'm happy that the general public finally realizes who we are. I think that in general in healthcare, it's traditionally doctors and nurses, which are very important themselves, but there's so much more to healthcare than, there's laboratory, there's respiratory, there's tons of people in imaging. So I'm happy that, the general public is kind of seeing all of our other areas, that our wait list has increased and the interest has increased. Yeah, it's fun. It's a great problem to have. Yep.
Well, thank you for coming on and letting us step into your world for a minute.
Thanks for having me.
Together, we got this.